Good evening. Today, I will be presenting a case of ascites under evaluation. Ascites is an important clinical sign rather than a diagnosis in itself. It often points to underlying pathology in the liver, peritoneum, or systemic conditions such as heart or kidney disease. This case is particularly interesting because the findings suggest a non-cirrhotic cause of ascites. Our patient is a 74-year-old Hindu male who is a farmer by occupation. He was admitted under general medicine on the 6th of September 2025, and I examined him on the 11th. Here, the background is significant. His rural occupation may expose him to infections like tuberculosis, and his advanced age increases the probability of malignancy. These demographic details already help us refine our differentials. He presented with 3 major complaints. 1. Progressively increasing abdominal distension for 2 months. 2. Abdominal pain with nausea and vomiting for 15 days. And 3. Decreased appetite, also for 15 days. The chronic nature of distension suggests a slow process like peritoneal TB or malignancy, rather than acute causes such as peritonitis. The associated anorexia and vomiting raise concern about systemic illness or intra-abdominal pathology. The illness began with insidious progressive distension. 2 weeks ago, abdominal pain developed, dull aching more on the right upper quadrant, occasionally after meals. Along with this came anorexia, weight loss, and decline in general health. He was initially evaluated at a surgical unit for gallbladder pathology, but symptoms persisted. This sequence highlights the importance of not anchoring to a single finding, like gallstones, when another condition may be driving the clinical picture. Importantly, he had no fever, jaundice, pedal edema, oliguria, hematemesis, or altered sensorium. The absence of these features argues against decompensated cirrhosis, portal hypertension-related variceal bleed, or severe systemic illness. This points us away from hepatic failure and makes us think about alternative causes of ascites. The patient had constipation, but normal urine output and sleep. His appetite was reduced. No history of addictions, which reduces the likelihood of alcohol-related liver disease. No hypertension, diabetes, tuberculosis, cardiac disease, or chronic liver disease. No transfusions or high-risk behaviors, making viral hepatitis less likely. This clean background is important because it forces us to consider extrahepatic causes of ascites more strongly. His daughter had lymph node tuberculosis 5 years ago, treated successfully. This family history is relevant because tuberculosis has environmental, exposure, and sometimes genetic links. It supports TB as a possible cause here. No family history of liver disease or malignancy. On examination, he was alert, conscious, and moderately built. Mild pallor suggested chronic illness or nutritional deficiency. No jaundice, cyanosis, clubbing, or edema were present. Crucially, he had matted cervical lymph nodes, which is a classic finding in tuberculosis, but can also be seen in lymphoma or metastatic disease. This clinical clue should not be overlooked because it often points us towards the systemic nature of the disease. His vitals were stable, afebrile, pulse 88 per minute, blood pressure 120/80, respiratory rate 18, and oxygen saturation 99% in room air. Stable vitals suggest chronic illness rather than acute emergency. This is consistent with the insidious nature of his complaints. The abdomen was distended with full flanks, umbilicus centrally placed. No dilated veins, no caput medusae, no spider angiomas. These findings argue against chronic portal hypertension and cirrhosis. No scars, sinuses, or gynecomastia, again supporting a non-cirrhotic etiology of ascites. On palpation, the abdomen was soft and non-tender with positive fluid thrill. No palpable liver, spleen, or lump. Absence of organomegaly is significant cirrhosis, congestive splenomegaly, and hepatocellular carcinoma become less likely. This shifts the focus to peritoneal causes. Percussion showed shifting dullness and flank dullness, classic for ascites. Liver dullness was normal again, ruling out gross hepatomegaly or shrunken cirrhotic liver. This supports the idea of free fluid in the abdomen without advanced liver disease. Bowel sounds were sluggish, but there were no vascular brutes or venous hums. This excludes mesenteric ischemia and Budd-Chiari syndrome. The sluggish bowel sounds may reflect pressure from ascites on bowel motility. Neurologically, he was intact, with no signs of hepatic encephalopathy. Cardiac and respiratory exams were normal. Genitourinary system was also normal. Together, this indicates a localized abdominal pathology rather than multi-organ failure. To summarize, Mr. Subal Mondal, a 74-year-old farmer, presented with progressive abdominal distension, pain, nausea, vomiting, anorexia, constipation, and weight loss. On exam, fluid thrill and shifting dullness were present, along with matted cervical lymph nodes. Taken together, this is a case of ascites, likely secondary to either tuberculous peritonitis or peritoneal carcinomatosis. Before moving to the discussion, I would like to mention, the following section is presented purely in the interest of patient care. It is not formally part of the academic case presentation, which is based only on history and clinical examination. Routine blood work showed hemoglobin 10.8 gram per deciliter, suggesting mild anemia, likely anemia of chronic disease. Total leukocyte count was normal, making ongoing bacterial infection less likely. Platelets were normal, so hypersplenism is not evident. In case of electrolytes, sodium slightly low at 134, potassium normal. Renal functions were preserved. But the striking finding was C-reactive protein of 300 mg per liter, pointing to a strong inflammatory or infectious process. Liver function showed mild hypoalbuminemia with reversal of albumin-globulin ratio. This could reflect chronic inflammation rather than primary cirrhosis, since bilirubin and enzymes were near normal. Importantly, viral markers were non-reactive, excluding hepatitis B and C as causes. Ultrasound abdomen showed significant ascites, gallbladder stone of around 2 cm, and bilateral renal cortical echogenicity suggesting early chronic kidney disease. Sputum CB-NAT for tuberculosis was negative. But a negative sputum test does not rule out extrapulmonary TB, especially peritoneal TB, where yield is often low. In ascitic fluid analysis, 1 liter of clear yellow fluid was aspirated. Biochemistry revealed total protein 4.7 gram per deciliter, albumin 2.5 gram per deciliter, that denotes high protein fluid. SAAG was only 0.31. Recall that SAAG below 1.1 gram per deciliter suggests a non-portal hypertensive cause of ascites, such as TB, malignancy, or pancreatitis. LDH was 260, ADA elevated at 40. Cell count 850 cells with 80% lymphocytes, typical for TB peritonitis or peritoneal carcinomatosis. Cytology was negative for malignant cells. Based on these findings, the differentials are tuberculous peritonitis supported by high protein ascites, lymphocytic predominance, elevated ADA, matted cervical nodes, and family history. Peritoneal carcinomatosis supported by anorexia and weight loss, but cytology so far negative. Lymphoma also produces lymphocytic ascites, but cytology not suggestive. Nephrogenic ascites possible due to early CKD, but less likely as a sole cause given the lymphocytic predominance. Our plan of management included repeat ascitic fluid cytology with larger volume to improve sensitivity for malignancy, hepatitis B and C serology as part of chronic liver disease evaluation, FNAC or biopsy of the cervical lymph node, since it may provide the most direct diagnosis. INI-CET abdomen and pelvis to look for peritoneal thickening, nodularity, omental caking, or lymphadenopathy. If TB is strongly suspected, empirical anti-tubercular therapy may be justified. Meanwhile, symptomatic relief with periodic paracentesis, nutritional optimization, and correction of electrolytes would be undertaken. In conclusion, this case demonstrates that ascites is a clinical syndrome with diverse causes. While cirrhosis accounts for the majority worldwide, in regions like ours, tuberculosis and malignancy remain important considerations. Careful history-taking, detailed examination, and strategic use of fluid analysis are critical in identifying non-cirrhotic ascites. This case also underlines the importance of integrating epidemiology such as family history of TB with laboratory results. Thank you for your kind attention.